actually,
Or no?
you know what? Maybe.
Don't we leave it
we'll
until the
just,
end?
no, I'll just safely remove it so you don't get any.
Oh yeah, I should do that right. So will I need to wear a microphone or?
No, actually, that's a
There's
microphone.
a mic here.
So,
okay. If I tend to walk around a little bit, is that going to be a problem? If you want me to
kind of do it this way.
Okay, let me know if you think it's not working. I can
Okay,
try
I'll
to stay here more.
I think it should be okay.
Okay.
Let me just recording. Oh no. Okay. No.
Okay. And you said I can remove this now? Yeah.
Actually, no, because I did.
All right, let's do it.
At the end, thank you. If you don't mind.
Health evaluation in a research unit. Yeah, in order to make a good acronym. Just ANS. Unit. So the cheer unit. I didn't develop that. I agree with you. I totally agree. No. Did you come up with it? No. The research previously has been around for, so this is the 15th year. So welcome everybody to another THETA round today. So we're having Lisa Prosser. Lisa is a professor at two departments. So it's professor at the Department of Pediatrics and Communicable Diseases and the Department of Health Management and Policy at the University of Michigan in Ann Arbor. He's also the director of the Child Health Evaluation and Research Unit there. And so she has been doing a lot of research around utility measurements, cost effectiveness, utility, specifically her research area is within family spillover, so she's really interested in this type of work. She's doing policy relevant work, especially around vaccinations, I believe, or so that's how I read her papers way before I ever met her for the very first time. So, because I'm doing a lot of work in vaccinations, and then I'm looking for utility values, and then it's pretty much always Lisa Prosser coming up first. So, yes, she's also a FMDM member, so we're all going to the Society for Medical Decision meeting in 2 weeks from now, and we will see each other again. So, I'm glad she's coming today. I told her already, so she will be discussing, as you all know, she was talking about comparative effectiveness and in child health. And I think we will get a bit of a US perspective today, which I'm looking very much forward to. But before we start, and I know some people hate it, but the rest of us lost it. We will just go around and everybody please say who you are. So starting, my name is THETA Sanders. I'm assistant professor at the Institute for Health Policy Management and Evaluation. I'm a scientist at Public Health Australia. Richard, you got it.
I'm Richard Sir. I'm a project manager at SickKids within technology assessment.
Wendy Unger, senior scientist and director of technology assessment.
Hi, I'm Jeff Hawks. I'm a health economist at St. Francis Hospital, and I teach at the University of Toronto.
My name is Sanjay Jalal. I'm
Hi, my name is Juan Rudy. I'm also a health economist at St. Michael Hospital.
William Moore, decision model at THETA.
This is with economy, headphones.
I'm Robin Hames. I'm a postdoc at the Institute for Health Policy Management Evaluation and do screening research.
I'm an embodied student at Ph.D. and also University Associate at
I'm associate program director at THETA and also director of clinical research, and I'm scientist at Lee Cushing.
I'm Lucy Abrahamian. I'm a clinical epidemiologist. I'm a master's student. Melanie Center. I'm also a master's program at the
I'm Nicholas Mitsakaitis. I'm University Station.
My name is Kirsten Beam. I'm also one of the research associates at
I'm Heinz Lowe, I'm a master's in health services.
Mario Costa, sitting body economics at the School of Global Affairs. And you see, I'm a course with the University of Florida.
I'm from China. Now I'm the research team of Marine.
Hi, I'm Emmanuel Wara. I'm a health economics analyst at Clear at St. Louis Hospital.
The outcome, pediatrician. And then also pediatricians are getting around scientific.
Thank you, everybody. Welcome, Lisa. So yours. And she told me before to also take questions during her talk. So don't need to wait all the way down. Great. Thank you very much for that really kind introduction. And it's really great to have everybody introduce themselves. You know, not everybody does that, and it's terrific to have a sense of kind of who's here and what people's backgrounds are. So I'm really delighted to be here today, especially given what's happening with the government in the U.S. right now. Maybe I'll stay for longer. So today I'll be talking about comparative effectiveness and child health. I'll start with some definitions and a brief history of PCORI, the Patient-Centered Outcomes Research Institute in the U.S., and the potential role for decision analysis in comparative effectiveness and child health. I'll then go through a case example of how we've used decision analysis to inform newborn screening policy in the states, what the policy process is, and a quick example of how we've applied that to considering Pompe disease for addition to the Uniform Newborn Screening Panel. And then finish up with some thoughts about where the research needs to go in terms of doing more work around applying comparative effectiveness specifically to child health. And I'm very happy to take questions along the way, so please jump in. I think we'll have a good conversation given the wide variety of backgrounds here. So just starting with a short history of comparative effectiveness in the U.S. So the term comparative effectiveness is still relatively new. It was introduced in the ARA legislation in 2008. But this concept has been around for a long time, and some related methods include evidence-based medicine, systematic review, evidence synthesis. For comparative effectiveness in the states, there are actually several competing definitions, and I would say that the definition of comparative effectiveness is still evolving at this point. So this slide shows the definition from HHS, which is the current definition that PCORI is using for comparative effectiveness. And I'm going to read through it because it's really broad, and it's useful to understand what the different possible components of comparative effectiveness are. So comparative effectiveness research is the conduct and synthesis of research comparing the benefits and harms of different interventions and strategies to prevent, diagnose, treat, and monitor health conditions in real-world settings, and this is an important point. The purpose of this research is to improve health outcomes by developing and disseminating evidence-based information to patients, clinicians, and other decision makers, responding to their expressed needs about which interventions are most effective for which patients under specific circumstances. So that's very broad. This could include a lot of different types of research. And we'll go through some of the examples and where the challenges are, specifically around thinking about all the types of research that could be conducted under this definition with respect to child health. But first, let's go through a little bit of a history of PCORI, the Patient-Centered Outcomes Research Institute. And the reason I'll go through this is because this is really where all of the funding for comparative effectiveness research is coming from right now in the United States, and that's the expectation for the years to come. So PCORI was created as part of the ACA legislation, the Affordable Care Act, and it's a nonprofit corporation, so it's not a government agency. And it's designed to, its charter is to assist patients, clinicians, purchasers, and policymakers in making informed health decisions. And The reason this is important is because when we think about patient-centered outcomes, there are multiple decision makers, and in particular when we think about it with respect to child health, that we're talking not just about the patient, but well beyond the patient. So we have parents, caregivers, potentially other family members. We can have teachers that may be a part of that decision as well. So the PCORI is designed to carry out research projects, or really they're not carrying out any research themselves, but they're funding external research through contracts to provide quality, relevant evidence on how diseases, disorders, and other health conditions can effectively and appropriately be prevented, treated, diagnosed, monitored, and managed. So it's really the full spectrum of care, anywhere from screening and treatment to as well as thinking about long-term questions of adherence. So PCORI was established as part of the ACA, and really, if you boil it down, it's looking at clinical effectiveness, risks, and benefits of 2 or more medical treatments. So that's kind of the crux of what PCORI is looking at right now. So there has to be a clinical question around comparing treatments, and treatments can be broadly defined. It can be screening, diagnosis, but there has to be a clinical question that's being informed. So in terms of the timeline, so PCORI was authorized in 2010. It's been very interesting to watch PCORI get off the ground. For those of you that are involved with SMDM, there are a number of SMDM members that have been part of the Society for Medical Decision Making, that have been part of the original board for PCORI, and it's basically been a startup. So it's not a government agency. So they started from basically nothing, and they came together and created a separate organization. So at the very beginning, often they said the conference calls were not about, what kind of research are we going to fund, what's our, along with our mission, they were trying to figure out, how they were going to have a meeting, how they were going to accept grants. And so for the first 2 years, all of their grants were actually submitted on paper, and they finally moved to an online system. So it's been kind of an entrepreneurial startup organization. I think some of that's reflected in how the definitions of comparative effectiveness have evolved over that time. So the first funding cycle happened in, actually this is a typo, in 2012. And the annual budget for PCORI is anticipated to be $500 million per year if it's fully funded. And the reason I say if it's fully funded is because we can see what's happening in the news with the Affordable Care Act right now. But if it is fully funded, it will be kind of the largest funder in the states for this type of health services research. So previously, AHRQ, the Agency for Healthcare Research and Quality, has been the place that has funded what could be construed as comparative effectiveness research or health services research in the states. But that, it looks as though, that charter is being transferred to PCORI, that right now AHRQ is funding a lot of comparative effectiveness research, but they're actually doing that, interestingly, with PCORI dollars. So right now there's a transfer back from PCORI to AHRQ to fund a bunch of comparative effectiveness research. And so we actually think over the longer term that there is quite a good chance that AHRQ may go away or may have a substantially reduced role in funding this type of research, and it's really going to be PCORI. And the reason that I provide that background is to talk about kind of thinking about what types of research are likely to fund it, in particular where cost effectiveness will fall within this definition. So the ACA created PCORI. The original conception was that this would be an organization that would have a mission similar to UK's NICE, that it would be able to look at both clinical and cost effectiveness of health interventions. But then when the ACA legislation came out, provision 6301 was included. And in this provision, it clearly states that PCORI shall not develop or employ a dollars per quality adjusted life year or similar ratio that discounts the value of life because of an individual's disability. So they're being very specific here as a threshold to establish what type of health care is cost effective or recommended. So this is a little concerning. So there are parts of the ACA legislation that talk at length about value-based insurance design, and this idea of trying to optimize care in the states. But then we have this very specific provision, which is clearly limiting the way that these funds are being used in the states right now. So what does this mean right now in terms of whether comparative effectiveness research includes cost-effectiveness analysis? So if we think about the different definitions, so for PCORI, they are not funding any cost-effectiveness analysis. So there was a question, over the first couple of years, there are many of us that are interested in this question, and we're very hopeful that with the passage of the ACA, that we would start to see some more decisions being made on the value of different interventions. But what has actually come to pass is that in the first 2 cycles of funding for PCORI, they were focused very specifically on patient-centered outcomes. And then in the very last round of funding announcements, they actually included this very specific language that cost-effectiveness analyses are excluded. So any application that includes formal cost-effectiveness analysis will be considered non-responsive. And not only that, but any application that directly compares the costs of care between 2 or more alternative approaches will also be considered non-responsive and not reviewed. So this is a little bit disappointing. It'll be interesting to see where this evolves over time, because it's clear that PCORI is funding research that's looking at the measure of utilities, and there's a lot of work that's being funded looking at patient preferences. And in fact, if you look at the leadership of PCORI, there are a number of health economists on both the Board of Governors of PCORI as well as on the methodology board. So it'll be really interesting to see how this evolves. But as of now, we cannot apply to PCORI for cost-effectiveness analyses. But on the other side, there are places in the states that are still funding cost-effectiveness analysis. So the IOM definition, the Institute of Medicine, actually uses a broader definition of comparative effectiveness research that examines differences in costs as well as outcomes. And the aim is to identify the approach that offers the better value. It does not necessarily promote or favor lower cost care. So other agencies that fund healthcare research, including the NIH, CDC, and up till now, the Agency for Healthcare Research and Quality, have been funding cost-effectiveness analyses either as part of or as standalone grants. But there is a lot of concern for people that are reviewing applications for these other agencies, that there may be spillover and that we may start to see other limits in these other funding agencies. Go ahead.
Do you know what the underlying reasoning of people
Rejecting it? Yeah. So, it's largely political, and this goes back to the history of, using cost as a decision-making criterion in the United States. So, in the 60s, when the Medicare legislation was originally approved, costs were excluded, costs cannot be considered as part of the consideration for adopting for including an intervention under the Medicare legislation. And so this follows very clearly, but it's even more explicit than what was originally included in the Medicare legislation. But what happened a couple of years ago is that there was a lot of hope, and in the original drafting of the ACA, it was clearly designed to include cost-effectiveness analysis. But then there were some very powerful opponents, including the pharmaceutical industry, that lobbied against the inclusion of cost-effectiveness analysis. And there, you may remember all of the news coverage about death panels a few years ago. Maybe you didn't hear too much about that here, but there was a lot of, as there was some beginning steps to formulate advisory committees about how to allocate resources within the ACA, that they were labeled death panels, and basically they just went away. So a little bit more of history behind the ACA legislation is that it appeared what happened to get that legislation passed is that originally there were two pieces: to expand coverage and to include cost controls, and that in order to get the legislation passed, they excluded the cost control piece of the legislation, and in addition to that, they actually explicitly banned cost effectiveness. So it's a little bit chilling. So we'll talk more about the other aspects of comparative effectiveness research. Any comments or questions about that? But I should say, though, that as of right now, there is funding that, and there are a couple of places within national health recommendations that are using cost-effective analysis that I'll talk about. Newborn screening today that does explicitly consider cost-effectiveness analysis, at least for now, and vaccination recommendations, which have included the consideration of cost-effectiveness since the inception of the Advisory Committee for Immunization Practices, more than 30 years ago. But so let's turn back and discuss some of the aspects of comparative effectiveness research and what some of the additional challenges are of conducting CER in the context of children's health. So in terms of conducting new studies, and this is a conversation we had a little bit over lunch, that conducting new studies in children is logistically and just in general more challenging and more expensive than conducting the same type of research in adults. There are human subjects issues that you're consenting, not just the child, but the parent and sometimes the child as well. And so that two-step process will actually, you'll lose subjects along the way because of that. That logistical, there's not just one patient to treat. Is the intervention directed to the child, or is it an intervention on the parent that will affect the child's health, or is it a group intervention? So it tends to be more complex. And also there's variation potentially variation in the effectiveness of treatments due to the age of the patient and the developmental stage, so a longer time frame is often more advantageous for interventions in child health. And when we think about synthesizing existing evidence, just in general, there's a smaller evidence base for children's health, for evidence for children's health interventions. Because of these logistical challenges, we have a smaller evidence base, and we also need longer time horizons. So even if we have a really good randomized clinical trial, say for a vaccine, it will only be for 3 years or 5 years, but what we really want to know is what the impacts are in adulthood or over the lifespan. So real-world settings. So again, there's a smaller evidence base, and that non-traditional settings may need to be considered here. So if we think about pragmatic clinical trials that are happening in the real world, that this may include other settings such as daycares or schools, which have not been included in pragmatic trials before. We need to consider multiple decision makers, and this is almost always the case for every type of child health intervention, that we need to consider parents and caregivers, preferences, how they impact the decision-making process, along with the patient, clinicians, other families, and maybe others. So where do we draw that line? How big does that circle go? Do we include teachers, other people that may be involved with the child's care? And again, this is going to vary by age, so that the decision-making is very different for an infant, where it's really a proxy respondent, compared with an adolescent, where it really becomes a joint decision-making process. So including all the multiple decision makers and incorporating their various perspectives can be more challenging for child health. And in terms of patient-specific outcomes, again, more difficult to measure in children. We had a conversation earlier today about measuring utilities for children's health, that there are no well-established methods for measuring health utilities, in particular for children under 5. So there's no identified methods, and so what you'll see in the literature is huge variation in how studies have been done to actually elicit utilities for children's health states. And again, we're not looking at the individual, but we're often interested in the family perspective, that there can be substantial spillover effects on family members for an ill child. And this is not just true for children. We also see family spillover effects for elderly patients as well, but how to measure and incorporate those is an important area for future research, and that Wendy and others in this room are doing research in this area already. And again, when we think about patient-specific outcomes and how we define those for child health, what are the relevant health domains? Do these vary by age for children compared with adults? Do these vary by age within children? So when we think of infants or school-age children, are the domains of health different, and should they be weighted differently? And how do we incorporate those into a health utility weight? Okay, so that kind of goes over the definitions of comparative effectiveness and some of the challenges that are likely to come up in applying comparative effectiveness studies to children's health. So one approach that can be used to mitigate some of these challenges is decision analysis. So the next few slides will talk about the potential role for decision analysis in conducting comparative effectiveness research. So for comparative effectiveness, so reviewing existing studies, we don't have many studies, so one way that decision analysis can be used is to actually synthesize the evidence in a way that's more general than a traditional meta-analysis, where we may not have enough studies that are similar enough to do a traditional meta-analysis, but we may be able to use decision analysis to synthesize those data and to understand, to take some broader conclusions from those sets of studies that are available. In terms of new evidence, in the next few slides, I'll go through some examples of ways that we can use decision analysis to actually produce new evidence. So I know most people here are very familiar with decision analysis. So what is decision analysis? It's a systematic approach to decision making under conditions of uncertainty. I won't go through all of the steps or some of the key steps that we typically think of when we go through applying decision analysis to a clinical or a policy decision. But in the end, what we're trying to do is to define a full set of alternatives and then to identify the alternative that's estimated to result in a maximum benefit, as well as the uncertainty that's associated with that projection. And that can be important for child health, particularly in understanding where we need to focus future research. So some of the advantages of a decision analysis approach for kids is that we can use decision analytic modeling to extend beyond the time horizon of a clinical trial. So if we do have data from a vaccine trial for 3 years, that we can then extend that beyond that time horizon for 20 or 30 years or the lifetime. We can simulate head-to-head comparisons of real and hypothetical alternatives. So, for example, one of our vaccination studies, before we had head-to-head trials of injectable vaccine and FluMist, the nasal vaccine, that we could use modeling to compare those head-to-head, where we only had individual studies that compared each of those vaccine options to placebo. It requires decision makers to explicitly define their assumptions, and this has actually been really critical in our application of decision analysis to newborn screening. And I'll go through some of the assumptions that came up during our process of using this with the Secretary's Advisory Committee for Heritable Disorders in Newborns and Children, where we were able to identify some areas where just in looking at the available evidence, that some of the assumptions that they were making, for example, around when we considered hyperbilirubinemia, that the experts were assuming that all cases of hyperbilirubinemia could be averted with screening. But when we went through this very systematic process of explicitly defining the assumptions and looking at each of the pieces of evidence, it became quite clear that there was a portion of these cases that could not be averted by screening, that these would occur anyway because there was no way to treat them. And this was really important to the committee, that instead of averting, say, 40 cases, that they were only going to be averting fewer than 20, so 10 to 15 cases per year. And this was critical in their decision making. So we can also use decision analysis to identify sources of uncertainty through sensitivity analysis and use that to prioritize and allocate research dollars. So this acronym SACDINC, this is the Secretary's Advisory Committee for Heritable Disorders in Newborns and Children. I will from now on call it the Advisory Committee. So the advisory committee has been using decision analysis for the past 2 years, and newborn screening is a really nice example of using decision analysis to help inform policy. So the policy question is universal newborn screening for a particular condition compared with clinical identification of that condition. And so the challenges in evaluating the evidence is that we tend to have really limited evidence. So these are extraordinarily rare conditions. Some of the more common disorders on the panel are, on the order of 1 in 10,000 newborns. Some of them are as rare as 1 in 100,000 newborns. So just because of the size of the affected population, we tend to have very little evidence. There are multiple endpoints that people are interested in. So, we're not looking just at deaths averted, but at long-term disability as well as short-term health outcomes. There are multiple perspectives, as we talked about, in the context of child health. And we're really interested in lifetime horizons. So, these are typically conditions where a newborn would either die or be very critically disabled within the first few months of life without screening and intervention. Okay, so this is not how this slide should look. Let me see if we can look at the next one. So let me just walk you through this process. So what this slide shows is the process for nominating a condition. And so how this typically works is that there's a nomination form that basically anybody can nominate a condition to be considered for addition to the uniform newborn screening panel. So like anybody in this room could download the form from the internet and fill it out and submit it for consideration. So it would then go to HERSA for administrative review, and at that point they look at two key criteria, and those tend to be whether there's an established screening algorithm that could be replicated, and whether there's an effective treatment. So if it makes this first initial screen, it then goes to the advisory committee, which would again review the nomination form and decide whether or not to send it for evidence review. So there's an evidence review group that I've been part of since 2004 that includes epidemiologists, ethicists, health policy experts, screening laboratory experts, health economists, and as well as a public representative. So on the commission review work group, so we would get the nomination and we would go through an evidence review process, create an evidence review report that then goes back to the advisory committee, and they would consider the evidence and vote on whether or not to add it to the uniform newborn screening panel. So I don't know if you can. You can't really see this, but you can see that, so in the past almost 10 years, there are 11 conditions that have been nominated. 6 of them have gone to full review. 4 of them have been rejected due to a lack of evidence, and 2 of them have been added to the uniform newborn screening panel. And so what happened when we go through this evidence review and synthesis process? Yeah, go ahead. So that's a really interesting question, because right now conditions are being nominated and considered on an individual basis. But often what happens is that when one condition is screened for, there is now enough information to identify other conditions from that. So what typically happens in the case for many health policy situations is that there are national recommendations, but then what happens at the state level can be different. So what I'm talking about here is the uniform newborn screening panel that is nationally recommended. Right now it has 31 conditions, but individual states are screening from anywhere as few as 7 or 8 conditions, all the way up to New York State, which is screening for, they have a pilot screening program that's screening for more than 100 conditions right now. So there's huge variation what's happening at the state level, and part of that variation is coming
have elected to just add those other conditions to their panel, and they report them at the same time, despite the fact that for many of those conditions there might not be an effective treatment. So that's a really interesting question. So that's for the ethicists on our committee, but has come up and will continue to come up. So let me just go through what some of the, yeah, go ahead.
How broad is that simple definition? You can argue that even knowing some of their metabolic diseases,
Yeah.
you might institute standard of care sooner, children are hospitalized, that they, so
Yeah.
it's a broad definition.
So it's pretty broad. It doesn't include palliative care. So the question right now of timing or really having information as opposed to changing the course of the illness is considered would not be considered having effective treatment. But at the same time, having an experimental treatment might be considered as an effective treatment, even though there is a lot of evidence. So it's really, there's a lot of interesting questions around newborn screening, well beyond the cost effectiveness question. So what has been happening in the evidence review group is that we'll go through, we'll be looking for all the typical categories of evidence that we would look for, going from best to worst, randomized controlled trial, down to observational descriptive studies or expert opinion. And this is really what we find. There are no randomized controlled trials of newborn screening that have been done in the States. I think there's one from Australia for MCAD, that might be it. And so we're really looking at, very kind of lower levels of evidence, cohort, case control, observational descriptive, and we have a lot of expert opinion. So we actually work very closely with our expert panels to develop the assumptions that go into the decision analytic models. Okay, so this slide is not working either. So this slide that that is not displaying correctly just goes through the history of the evidence review for the advisory committee. So in 2004, the committee started considering conditions. So I've been part of that evidence review group from the beginning. In our initial proposal, we proposed including decision analysis to address some of the issues around the lack of evidence. Unfortunately, they stripped it out and didn't fund it as part of our original proposal. So until 2 years ago, we would review the evidence and we would come back to the committee, and there would be very little evidence within that report. There would be a lot of expert panel opinion because that was the bulk of what we had to report at that point, case series, and those types of evidence. There are 2 health economists on the panel, and so cost effectiveness is actually one of the categories of evidence that is included in this process. But given the nature of these conditions, we would go through the evidence review process, and then we would write our paragraph saying, there are no cost effectiveness studies here for this condition. So in 2011, we paused, and there was an evidence evaluation methods working group convened to evaluate the evidence review methods and to formally consider modeling and approve it as a validated approach for evidence synthesis. Part of the pushback earlier had been that this has not traditionally been used in other evidence review groups for considering policy in the States. So they recommended the use of decision analytic modeling. We so far applied it both to hyperbilirubinemia and to Pompe disease. And the role here is, given the time frame that we have for considering these conditions, that disappointingly there really isn't time to do a full-blown cost-effectiveness analysis. So the objective for using decision modeling here is really just to create some simple models as an approach to evidence synthesis to project ranges for population-level health benefits and potential harms. And so I'll go through a quick example for Pompe disease. So Pompe disease is a lysosomal storage disorder in which newborns cannot process glycogen. It accumulates in their tissues, and they experience muscle weakness and a number of other symptoms. There's a very large spectrum of illness.
the infantile onset cases, which is the condition that was actually nominated for addition to the newborn screening panel, infantile onset Pompe, is the most severe, and that without treatment, they usually die within the first year of life if they have classic infantile onset. There's also non-classic infantile onset, which they have longer survival but are likely to die within their early childhood. But then there's also this group of late onset Pompe, and this is an important category because when you're screening for Pompe, you don't know at the outset which category the newborn is going to fall into. So they can tell from symptoms, so from evaluating the child, whether they have cardiomyopathy or whether they tend to have infantile onset. But for these later onset patients, there's now a category of patients that will be identified that we don't know when or if their disease will ever present. So this slide shows the timeline for the review for the Uniform Newborn Screening Panel. So for Pompe, it's nominated in May of 2012, and then we have about 12 months from start to finish to do the evidence review and the decision analysis. So during that time, we conducted 3 expert panels to develop the decision analyst model and then present the draft results to the advisory committee. And again, the objective was to project key outcomes for newborn screening compared with clinical identification. So in collaboration, I'm going to skip this slide because we'll go through it with the expert panel slides in a few minutes. But so in terms of the process, so we would go through the standard evidence review that we had done previous to 2011, searching the published literature, gray literature, interviewing experts, and then using that information from the evidence review, we would develop an initial decision model. We would then work with the expert panel. So this slide shows the objectives with our first expert panels in December of 2012 and January 2013. So we conducted all of these by webinar. We reviewed the role of decision analysis, try to give them a little bit of background as to what we're doing. We would go through the draft decision tree in detail, walk them through every branch of the model. We also went through with them a draft of key outcomes and reviewed modeling assumptions. And this is an iterative process. Our objective was consensus if possible, but that's often not, for those of you that have worked with expert panels before, often that's not possible. Really the goal is to try to create ranges around parameters where we don't have good data to create a plausible range that we can use for that parameter estimate within the model.
Lisa, I have a
Yeah,
question.
sure.
What kind of people are the experts? Who are the experts on this?
So these are clinical experts. And so, again, when we're talking about these rare conditions, so for Pompe, there were 6 experts. And they are basically the 6 people in the United States that treat these patients. And so, and the patients travel from all over the country to work with them. So thanks for asking that question. These are clinical experts. So this just shows the basic structure of the model. So we're comparing newborn screening to no newborn screening, which is clinical identification. So this slide shows our initial draft model. I'm not going to go through it in detail, but the important thing to consider is that we have here all of the screening outcomes. So we're interested both in short-term screening outcomes, so understanding in particular how many false positives there are likely to be as a result of screening, and then the long-term outcomes. In our first draft, we were looking just at survival. So how many deaths could be averted through newborn screening. This slide shows the comparison for clinical identification. One of the key questions that we had for our expert panel is, if there were information on these, any information on what the likely trajectory of disease would be for those patients that had later onset, so that we could try to include that in the model. So this slide shows the initial draft of the key outcomes that we were focusing on in the model. And it was an iterative process. So I also want to mention that not only did we include, we had expert panelists that we worked with over the course of the 6 months. That we had 3 formal expert panels, but we would also email with them along the way as we were updating and revising the model. But we also had 2 liaison members from the advisory committee, and this was really important to be able to bring them through the process so that they felt comfortable with the model and the assumptions that were being made. So the next few slides just show a flavor of some of the data or the lack of data that we had. So this is very different from the types of laws when we think about vaccination programs that, there we typically have, several randomized controlled trials. We can do, meta-analysis to estimate to estimate vaccine effectiveness. We're really at the very other end of the spectrum that we have very little data. So we did have one really good study from Taiwan about the characteristics of the screening test, but we did have to adjust those to reflect the different characteristics of the population in the states. So we already made some adjustments there. But then when we look at the prevalence and subtypes of Pompe disease, so we had pretty good information on the incidence of Pompe with newborn screening. We didn't have good data on what the incidence was under clinical identification. So we had a huge range, and we worked to try to identify some estimates for those parameters. And again, we had some point estimates for some of the other input parameters, but we worked with the expert panel to develop ranges for those. This slide shows the 36-month health outcomes. So we're looking in particular at we had pretty good data at 36 months, so we looked at 36-month survival as well as ventilator-free survival. So the newborns that have the severest form of disease tend to require ventilator, become ventilator dependent within the first year of life. So those were our main health outcomes, mortality and ventilator-free survival. So we further simplified our decision tree, as if it couldn't be any simpler. And then I show this slide just because, when we work with the expert panel and we start to describe decision analysis, there's clearly this reaction that it's just a black box and they don't know what's happening in there. So the process that has been designed for newborn screening is to make sure that they're included with the advisory committee liaison members throughout the process so that they feel comfortable with the assumptions that are going to the model. And the other piece is that we've kept the models really simple so that there isn't any, anything that is confusing. So I'm going to walk through the results that we presented via webinar, and this is important. I'll talk about that in 2 slides, and then I'll wrap up. So we went through the analytic approach. We reviewed the model. This is the final meeting during which they're considering all the evidence, and then they'll be voting on whether or not to add it to the panel. So assuming an annual U.S. newborn cohort of 4 million, so our model projected that newborn screening is projected to identify 134 cases, including both infantile and late onset Pompe. And of these 134 cases, that 40 of them would be infantile onset. So this is the category that the nomination form included. But 94 cases are expected to be late onset. And before we did our modeling, that this was really an open question, that there weren't any good estimates of kind of what the size of that population was likely to be. And this was really important to the committee. And actually, this is where all of the discussion hinged when they debated whether or not to add Pompe to the panel. So we were able to confirm, what the number of cases were for infantile onset, and to be able to quantify the number of deaths averted and the number of ventilator-free cases. But really, the discussion hinged on, the size of this population, that we didn't know, whether these patients would ever demonstrate disease or not. One of the other things that came out of the modeling was that enzyme replacement treatment, which is the treatment for Pompe, is relatively new. And so most of the natural history data that we had was natural history data based on clinical identification without treatment. So one of the important messages that came out of the decision model was that we needed to be very clear that we were comparing newborn screening with treatment to clinical identification with treatment, because those newborns that are now identified through clinical identification receive enzyme replacement treatment. And so the magnitude of the benefit is very different than if, what we're really talking about here is the initiation, the timing of the initiation of treatment, not compared to no treatment at all. And that was also an important outcome for the committee deliberations. So just in terms of the overall process, so what happens during that meeting is that the evidence review is presented, population impact modeling is presented, feasibility of screening, so how well are states prepared to take on the screening of this new condition. The benefits and harms are evaluated using a condition review decision matrix that was developed specifically for newborn screening. Then a recommendation is made to add it to the panel or not in a vote. And so Pompeii was added to the panel, but with specific attention to this group where studies need to be done, follow-up long-term studies to understand what is happening to those patients over the long term. The other reason I wanted to mention that this is happening via webinar is because in terms of the policy process, so the other thing that has happened in the States, earlier this year we were affected by the sequester, which required every single federal agency to take a mandatory 10% budget cut. And so these meetings used to all be in person in DC, and now they are all done via webinar, and it has become a very different process. So this slide shows what's happening when people are presenting via webinar. So there's a slide here, there's a closed captioning here, you're listening to the person presenting their presentation, but then there are all these public comments happening in the side. So people can actually be, it's like a blog that's happening at the same time. And it really changed the flavor of the conversation. So just wanted to mention that because it was, I think we're likely to see this happening more and more, especially in the States. And it has really changed the flavor of the discussion in not such a positive way. So let me just wrap up with a couple of observations. So for Pompeii, the use of decision analysis improved the transparency regarding assumptions, and especially this question around the comparator, that it was clinical identification with treatment, and identified knowledge gaps and where to prioritize future data collection. And then stepping back more broadly to the role of decision analysis in comparative effectiveness research, that it can be used in evidence synthesis and estimating long-term outcomes, and it's the underpinning of most cost-effectiveness analyses, although we don't see that happening in the short term in the States. And there are a number of examples where decision analytic modeling is being used in the US, and I've listed those here. But when we think about comparative effectiveness research in child health, some of the key challenges moving forward is how do we overcome these practical challenges of recruiting for and conducting research in pediatric populations? And how do we address this lack of long-term data? So, we don't have long-term longitudinal data sets in the States. We have the National Children's Study, which has just been started in the last few years, but it'll be quite some time before we see any data from those studies. And then in particular, how to define patient-centered outcomes in the context of child health. And who does this include, how to draw those lines. I know there are many people in this room that are thinking about those questions. I think that will be a really important area of research going forward. I just want to acknowledge my research team. Great, thank you very much. And I'm sorry I haven't left too much time for questions. Is there time for a couple of questions? Comments? Dismay over the lack of cost-effective analysis? Yeah.
So what's the condition that I think Pompeii does screen for?
So it's been recommended for addition to the panel, and it's now waiting for an official recommendation from the Secretary of HHS, which may happen when the government reopens.
So once the condition is approved for screening, is there some type of surveillance system within monitors the prevalence of this condition?
So that's a really good question. So right now there are regional traditional collaboratives in the States doing long-term follow-up, but they have, this is another classic example where they have a lot of autonomy in deciding exactly what they're going to include in that long-term follow-up. So that's not clear yet.
Observation, I mean, it strikes me that if you're in a country which is behind the eight ball a little bit on screening, you wonder about the role of helping other jurisdictions have the kind of data, so the ones who have actually expanded their newborn screening to be collecting the kind of data that Wendy was talking about. And we need a lot of them to do it because these diseases are so rare. So for sure, in this province, we need the newborn screening data now to help us data, so you can actually start to take a look at, again, just the health services, at least the healthcare use, and some of the kind of data that you would need to consider those conditions. But you wonder about the role of actually the U.S. funding some jurisdictions that don't have a lot of funding to do that kind of data industry, but for the greater good, right? It's for other people so that they can then model it and decide whether it's applicable, what their own decisions are going to be for the population.
Absolutely. And there has been, so there are some conditions that some states have pilot programs for and have had those in place for a few years. So we can use those to include as data when it's considered for national recommendation. But the long-term follow-up has been just slow to get off the ground. So I think it's really started up in the last year.
I'm just curious, in Ontario, we have an audit Pompeii, and we have a review process that essentially includes the evidence review portion, but not the decision analytic component. And the feeling very much in Ontario has been that this later onset group is really a concern, and it's sort of been holding people back from wanting to pursue. So I'm just wondering more concretely, what pieces of the decision analytic modeling results help to sort of tip that balance among the reviewers?
So, well, it was one piece was that we're able to provide population level estimates. So from the published literature, we didn't even have a sense that we could say, how many cases per year. So we're able to put a number and a range around that. That would be 40 cases per year. And so I would say that piece really was very important. Let's say by not including cost effectiveness analysis, though, that there's a piece of that I don't know if this is part of the conversation here, but the enzyme replacement treatment itself is enormously expensive. I mean, it's on the order of $200,000 per patient per year. And that in Europe, at least in one country, is actually just taking it off the formulary. So they're now screening for Pompeii, but basically there's no treatment of it to pay out of pocket. So that's another hold that of issues that is not being brought in. But so for the decision analysis, it was really quantifying exactly what the health benefits were, as well as being clear about what assumptions were going into that. And in particular, identifying this group of late onset, which there was a lot of discussion about. And it really went back and forth. It wasn't clear which way it was going to go.
Last question. Are prenatal screenings at all considered by the committee as income technology?
They're not, no. So this is really for newborn screening that happens in the first 2 weeks of life. Yeah. But I would say that there is a lot that decision modeling can do to help evaluate those decisions as well.
That's a good question, but to wrap up,
Thank you very, very much. Great. Well, thank you. Thank you for having me.
Thanks, everybody, for coming.
and thanks for the evaluation corner before you
Yeah, I would have invited you, but we'll keep it 2 weeks.
Yeah.
Thank you so much.
Yeah.